sometimes angry at the person who shows up to help them. I see a lot of head nods. And that can be something that comes out a little sideways. Often anger is used and is a cover-up for things like grief and for sadness, especially with men. We're far more comfortable being angry than we are being sad or feeling significant grief. Anxiety, feeling out of control, again, pretty normal. People get anxious about all of the paperwork that needs to be filled out for insurance forms or what have you. It only becomes a concern when it inhibits someone's ability to problem solve. When somebody can't make a decision, then it becomes problematic. And then guilt. What did I do to deserve that? We're seeing some of that in veterans who are saying, well, I shouldn't have messed with such and such toxic thing. You know, we don't know what causes this disease. It's not really worth beating yourself up over, but people will do it. Reactions of family members are identical. The additional one is exhaustion. People work so hard to keep it all together, and there are so many things physically to do. Emotionally, this is difficult, that they get so tired. And one thing for you to know is that often that is when they call and say, I'm at my wit's end. I just don't know how to do this anymore. And that's when they'll sign up for the respite program. And that's when we call AgeWell and say, oh, can you come provide services to this family? So something for you to know as you walk in is that this family may be just really needing a lot of help and support. And the more gentle and compassionate you can be, the better, as they are working really hard to keep it all together. Resources for families, for people with ALS, the support groups and other chapter programs that have been mentioned. Often a faith community can be very supportive. A lot of folks have visiting programs that can come out just to visit, keep someone company. Share the care or lots of helping hands can be helpful in terms of accessing resources for people to get chores done and the like. And then of course there's always professional counseling, medication if that's needed, and at a certain point hospice when that becomes the family's desire. Feelings of healthcare professionals. Intimidation. All of those slides of all of that equipment. When you walk into a home and you know there's maybe communication devices and 2 or 3 wheelchairs and a walker, it can be a little overwhelming. It can also be tough to talk with someone whose speech patterns might be affected by the disease, who maybe use a different kind of device that you're not familiar with for communication. Another thing that can be intimidating is the progression of the disease, quite frankly. You sort of get into a system with the person you're caring for, and you get a routine going, and the disease progresses, and that has to shift and change. And it demands a certain amount of creativity on the part of healthcare providers as well to shift and change with the changing needs of the person. Frustration in dealing with the disease, in dealing with a person, maybe not understanding them. And I will say that the understanding can be very hard. And with practice, it does get easier, but that can be a barrier for a lot of folks. Guilt over being healthy, over being able. The person may say, oh, you know, I used to be as strong as you are. Sometimes there isn't a response to that, and it's okay to say nothing. If you have a good response, share it with your coworkers, But just know that that's a tough place to be, and it can be awkward, and that's okay. And then grief and sadness, of course. I know several of you get assigned to see the same families over and over again, so maybe you're there every Tuesday with the same person, and you watch them get more and more ill and more weak. Having to say goodbye if they end up going to a nursing home, and certainly when they die. Those can all be tough situations. Resources are available. You can certainly support and debrief with your coworkers. I don't know how often you get to see each other. Of course, there's always patient confidentiality, but just having a chance to chat with other people about what's going on for you. Seeking consultation on a difficult case. Your nurse is always available for you to call and say, whoa, this happened and I'm not quite sure what to do, or they have this new piece of equipment and want me to use it and I don't know that I can do that safely. Please seek out additional resources. If it's something that you're feeling like, ooh, this is really emotional for me and has nothing to do with the family, and you think maybe you need professional counseling, by all means, seek that out. Most important is to remember to take vacations, to be with people you love, to spend time doing things that you enjoy, and to balance work and fun. One of the things that I remember when I first started a year ago, somebody saying, oh, well, I don't feel like I can go on vacation because maybe my client will die, and I would feel horrible if I wasn't there for that. The truth is, you need a break, and you can't live your lives based on your patient's needs. It is a job, and the expectation is that you'll do it well and will enjoy your job longer and do it better if you get the support you need. If you are feeling like, ooh, maybe I'm getting too involved, very quickly, some red flags if you're sharing too much information, personal information with a family, spending time outside your usual work duties. You know, your patients should not be on your pampered chef invite list. And if you're providing services which are outside your job description, you know, dropping off library books or going to the grocery store, things that we need you for the skills that you bring, not for skills that other people can do. And if ever we can be of service to you, or if the family member says something about, boy, I wish we had a volunteer who could do this, or I really think we need a therapist for our family, or whatever, make sure to say, you know, you can call the chapter. We are here for patients, for family members, for friends, and are happy to help in whatever way we can. So you'll take all of these little forms with you, I'm sure, and have our contact information very handy. Thank you for being here today. We are going to move into another period of questions. So maybe we'll just hold the microphone up here, and then if folks have questions, we can direct it to whoever can best answer it. Yes, go ahead.
I'm not quite sure what your name is. Jennifer? I have a question for you. The bathroom equipment and stuff that you showed, is it just for ALS? Oh, it was you, I'm sorry.
Me, that's right. The question was the bathroom equipment and the other items that we showed,
Yeah.
are they just for ALS patients? And yes, that's true.
Okay.
You know, there are other loan pools in the cities in the metro area that are available for people with other diagnoses, but they have to have a diagnosis of ALS.
How do you get a hold of the right, for different diseases, how do you get a hold of the different pools? Yeah, say one has cancer, one has a stroke. I mean, they're different. Where are these?
Where are they listed?
Yeah.
You know, I think that if you, Jennifer knows.
social worker here. Actually, I think there's probably a lot of ways that you could pursue that information. You know, if you're, one of the first things I go to is Google if you get online. But something that I think is worth mentioning is that AgeWell is part of the Care Options Network. And because of that, may have books on hand with information for all of those different associations. I don't know if Kimberly, you have any other ideas? And they, okay, yes, and of course, as Ann mentioned, go to your nurse and see if he or she has ideas about how you might be able to get what's needed for your clients. Yes.
Yeah, person has ALS, is diagnosed with ALS. Whom should you tell first, and when should you tell?
So did you say you're working with a client right now who has ALS?
Diagnosed with ALS. Whom should you tell first?
Oh.
And when should you tell?
At the organization?
When you're first diagnosed.
Yep. Okay, so when somebody is first diagnosed from their doctor with ALS, the question is who should the person with ALS talk to first and when about it?
Yeah, whom should the doctor tell first?
So if the question is who should the doctor tell first about the ALS diagnosis, my response to that would be the patient. The person with ALS should receive information about their diagnosis first. Does that answer your question? Okay, okay. Yes, I think I saw a hand up right there. Brown plaid shirt.
Yes, the equipment, how do we go about acquiring it in terms of compensation? Do we get it free completely?
So the question is for looking for equipment for persons with ALS. How do you how to acquire that equipment so the patient can use it? Okay.
If someone needs a piece of equipment, then either they or their family member or one of the healthcare professionals involved just needs to call the chapter, and we'll check to see if we have that item available. It's important that we know that piece of equipment is the right piece of equipment for that person. And so if there is someone who has evaluated that, we would want to know that. But it's free of charge, there's no cost. And if the person, depending on where the person lives, the item will either be delivered to their house or it will be shipped to them. Or if we don't have the item, then they're put on a waiting list, and as soon as their name comes up, we call and find out if they still need it or not, and then we'll arrange for delivery. Yes?
I have two questions here. One is coping with ALS.
Okay.
When you talk about denial, sadness, and all of these things, do you not talk about acceptance? Do the patients not talk about acceptance of the disease?
That's a great question, and they do. The question was, in terms of all of the ways of coping with the disease, acceptance. Is acceptance not one of those? And absolutely, you're right, thank you. I guess I don't have a lot more to add to that. There are certainly accepting sort of what's happening with and still being angry at the disease. I mean, it sort of all gets tangled up together. So so I don't know if there's more specific to your question.
No, because I didn't see it as part of.
Yeah, you're right, and it should certainly be on there. Lisa wants to add something.
I just wanted to add one thing. That was an excellent point about acceptance, but I have personally worked with people, I think as my colleagues have, that in maybe what is perceived as they never accept it. I mean, we have literally had people who go to all 4 of those, or at least 3 of those ALS clinics, looking, hoping, wishing for a different diagnosis than ALS. And you could argue that that was how they were dealing with it. They just needed to do all those things, but everyone accepts at a different rate, but it has to get to that point.
The second question, I think, do people with ALS get misdiagnosed, like with Parkinson's and other things?
Sure. A great question, and I'll take it. The question was, do people get misdiagnosed? And yes, they do. Probably not with Parkinson's, probably not with multiple sclerosis, but they get misdiagnosed with some other things. There are some even more rare diseases than ALS that a doctor might think that they have. So again, it goes back to that diagnosis of exclusion, that they have to do all these different tests to rule out every other disease. So eventually they come around to ALS, and it gets even more complicated than that. But yes, the answer to your question is yes, some people do get misdiagnosed. Other questions? Yes?
In dealing with patients with ALS or multiple sclerosis, although we're not talking about that, but they are interrelated, why is it more difficult to take care of women with those diseases than men?
Who's our gender-specific expert? What way?
As you guys taught us and what I understood, their limbs, their extremities, they can't move it. I was dealing with one of them before. The women will kind of say, hold my hand this way, you put it this way. When you hold it, say, put it the other way, put it the other way. Put it this way, put it this way. Oh, my hand was this way.
So
It's harder to take care of women than men with those diseases.
So the question is, why does it appear to be more difficult or challenging to take care of a woman with ALS than a man with ALS? Now, that's interesting that you say that, because there were a lot of people shaking their head that they have that same experience. I can tell you I've had lots of experience with men where people just pull out their hair going, why do they, why are they so particular? So I personally think it's more to the personality than I do think it is to the gender. However, I always tell people too, if you couldn't move or reposition yourself, imagine how awful that would be. So sometimes I lay in bed at night and I just lay still and think, I'm really miserable on my back. I would move to my right, but what if I couldn't? What if I couldn't even scratch my nose? And so it really is a difficult thing. So it might be a control issue. I don't know if you two agree that, you've moved me, but I'm just going to I can't control much about my disease. I can't control much about my life, but darn it, I am going to control where my hand is. That might be.
There's also, and this is true for people with ALS, but people with a lot of different diseases, is that they don't get touched as much as other people do. And so there can also be just wanting to be physically touched, whether it's moving or whatever. So it might just be something coming out sideways as well.
Yeah, but then don't you think it has to do with denial? I mean, does it mean that women are more being denial compared to men?
It's interesting. I don't know that I've heard this gender disparity before, so I don't know what the difference is. No. Go ahead.
Is there a difference between ALS and MS?
There is a difference between ALS and MS, and since there's a nurse in the room, I'm going to turn it over to her.
Yes, there is a difference. Some of the symptoms might look similar. However, what's happening in the body is very different. I talked about the motor neurons, or the nerve cells that are being damaged in ALS, so that a message from the brain can't get down to the muscle of your arm to move it. In MS, there's a plaquing in the brain that is also interfering with the ability of the body to do what it needs to do, but it's happening in the brain more so than the motor neurons are not being affected. So again, symptoms could look the same. Most people with MS have the potential to live many, many more years. It's not always a terminal diagnosis where ALS is. Okay, so many good questions.
Yeah, how long has it been since this disease was been diagnosed?
Sure, the question being how long has it been around, this disease? Probably in the late 1860s, there was a French neurologist who first identified those symptoms and kind of called it motor neuron disease, or here it's called ALS. So 140, 150 years, and we don't know what causes it.
I have a quick question.
Sure.
No, I know you said it's through process of elimination, that's why it takes so long to diagnose. But if you take the EMG right away, that can tell the neurons, can you do that right away, or you have to go through the process?
You have to go through the process. So the question is, couldn't you just simply do that EMG, that muscle testing, and be done with it? No, you have to rule out other things, because an EMG could be abnormal for other reasons too. So you must go through that process of eliminating other diseases causing the similar symptoms, and then looking on EMG for those upper and lower motor neuron damages. But good question. Wow, you guys are amazing.
Thank you.
How about the gentleman in the gray sweatshirt, and then we'll go next to you. Yep, that's you.
Besides the medication, is there any other process, is there any other means of detoxification?
Detoxification. So other than the medication that's FDA approved, is there any other way to detoxify this disease from doing damage? Is that correct? No, we know of nothing at this point. Simple answer. Yeah. Yes, sir.
Yeah, it's almost similar to this question. Is there any way, as a family member, to avoid ALS?
Okay. The question is to avoid, is there a way for a family member to avoid getting ALS? So,
It's already in your family.
yep. Then at this point, so for those 5 to 10% of all the cases of ALS that have the genetic form of ALS, there's no way to stop it at this point. We know of no way to prevent it from happening. So if the odds are that you are going to get it because you've inherited the gene for ALS, there's nothing we know to stop it at this point, unfortunately. But keep in mind, 90 to 95% of the cases are sporadic. So if you have a family member with the disease, you will not get the disease, okay? So how about the lady in purple, and then we'll go to the back row there.
Is there any special training for this ALS? Special training to the caregivers?
Is there a special training for caregivers caregivers who take care of people with ALS? I think this is it. Yeah, that's one of the reasons we're here, and we go to other home care agencies, we go to other nursing homes, all of us here, we do in-services, because, I mean, there are so many diseases, you couldn't possibly be expected to know everything about every disease. So we come here, and we're grateful to come here, because you guys do such a good job of taking care of these folks, and we want to keep you, or make you as informed as possible, so that you can even be better caregivers. But as far as any other special training you could take at the Red Cross or anything, no, unfortunately not. And then I said in the back.
Okay, as I understand, ALS is a hereditary disease.
The question is ALS a hereditary disease?
I just want to say something. If it is,
Oh, if it was?
and you're born into a family that has like ALS, is there a way that you can start doing testing a little bit early?
Oh. A very good question. So if you are in a family, that 5 to 10% of the cases that have the genetic component to the disease, it's super complex. So let me just say, if you wanted to know if you have the gene, you first have to take a person who has ALS and test them with a blood test to make sure that they have the mutation we know about. So this is where it gets complex. If we took those 5 to 10% of the cases that have the genetic form of ALS, and we do a blood test for the mutation we know about, only 20% of them are going to test positive for that genetic mutation, even though we can look and say, oh my gosh, your uncle, your dad, your cousin all had ALS. We know it's the genetic form, but they might have a false negative. So that's why blood tests alone are not helpful, and where genetic counselors are more important. But let's say somebody has tested positive for that mutation we know about, then yes, you could then test other family members to see if you have the inherited gene. If you do, you would have a 50% chance of getting it. So just because you have the gene does not mean you would get the disease. So it's very, very complex. Oh, sorry, this, unfortunately for time's sake, is our last question.
I work with a man that has ALS, but his wife had to train me to do the things that.
His cares?
Yes, huh?
His cares?
Yeah, she had to train me for all that, the training, for the caring, how he feeds himself, how he does his computer, the little thing he puts on his finger. His wife, she had to train me to do all that because nobody else could train me.
So if people didn't hear that, she was saying that when she went to provide the care for the person with ALS, it was the person with ALS, their spouse, who had to teach her how to do that thing, do the cares. And that's pretty typical, unfortunately. I mean, there are some things that we all know as healthcare providers, but there are some specific things that people with ALS might need, and who better to train you than the person who does it 90% of the time. Okay, thank you, everybody. We are so grateful for you to be here. Thank you.